Okay, if everybody could come to order, I think we'll get our session started. This is a session called One CTO, Many Paths, Aligning Strategy and Execution. It's sponsored by our great friends at Asahi Intech, and we want to thank them for their support. This is one of literally hundreds of things they sponsor to help all of us learn more and teach more about chronic total occlusion angioplasty, complex angioplasty. And I think it's a great title to what hopefully will prove to be an interesting and educational session for all of you. My name is Aaron Grantham. I'm from St. Luke's Mid-America Heart Institute in Kansas City, and I'm joined by Scott Harding, my friend and colleague. And I'm going to turn over the mic to Scott, who will introduce our first speaker and get us started.
Hi. I'm going to introduce our first speaker, Raja Hatem, who's from Hospital du Sacré-Cœur in Montreal. He's going to be talking to us about what wire do you start with, XTR or Gladius MG, and why.
Thank you very much. It's a great pleasure and an honor for me to be here. Great pronunciation on the Hôpital du Sacré-Cœur, Scott. I'm impressed. So I was joking with my friend Aaron here, like, how do you do 15 minutes on a wire talk? Well, I'll even complexify it even more. I'll do it on one wire, and we'll focus on that one because it's one of my favorites. So these are my disclosures. So what better way than to use a case? So this is a 75-year-old female. She has a history of CAD, which we'll walk you through. So she had an NSTEMI in October 2025, for which she had a PCI of an RCA and LAD, and she also had a functional CTO of the circumflex. It was briefly attempted, antegrade, and I'll show you the films, and it failed, so she was referred to my CTO clinic. Despite medical therapy, she remained symptomatic, hence I scheduled her for a procedure. So let's go back to her original film. So these are the films from October 2025. So we see here the severe lesion on the LAD up top, and we see the functional CTO with still antegrade flow, although it's TIMI2 flow, but we call it a typical functional CTO. So on the right side of your screen, you see the actual attempt from my colleague. And he actually, didn't just use a wire. He took the time to bring a microcatheter, and he tried two different workhorse wires. And this is one of my older colleagues from the generation who always taught us, be patient with your wire. I could do anything with my workhorse wire. I just need to be patient. The way I was trained is completely different. So I was trained with Dimitri in New York, and the attention span was very short. If an equipment didn't work, you use a different equipment, and the better you know the properties of your equipment, the faster you get your cases done and safer. So this is the failed attempt. We see that the workhorse wire just buckled against the proximal cap right in the beginning of the CTO, and it unfortunately didn't work. And he actually tried for a solid 30 minutes, and it didn't work. So these are the final images of the procedure. So you see that the LAD is stented. And this is the final image of the right, where you do see some collaterals going to that circ CTO. I would not say that these collaterals are very interesting. If you're looking at retrograde options, you don't quite see them well, and they don't seem to be big enough. But you still have that distal visualization. So I brought her back in December in 2025, and this is what it looked like just 2 months after the initial procedure. So you already see that the antegrade flow is worse than it was, and we all know that eventually these functional CTOs, they advance and evolve and end up being complete CTOs, and here we're not far from that. So you see here, one thing that I don't do, that I did here, is I did not use dual injections, and I'll tell you why. It's because I was so confident that with the proper equipment, I was going to be able to resolve that case antegrade and quickly, that I didn't do a dual access. But usually, for the vast majority of my CTOs, I always have dual access to have that visualization of the distal bed. So before showing you what I did, I'd like to hear from the panel and my esteemed colleagues what they would do with a case like this.
All right, I'm going to call on Jarrod Frizzell. Jarrod, what's your approach to this case?
So given that there's not really that much flow antegrade, I would This is when I think about dual injections. But as far as wire stuff, I'd use a Gladius MG with no bend on it and just shoot it right in.
Interesting.
It's surprising how often that works. Like, don't put a bend on it. Don't put a micro bend. I think Bill calls it the God bend. You just throw it in there like God bend it. But I'm 90% sure that's just going to fly across.
Maoto, what would your approach be and which wire would you choose?
First, so I'd like to check chip injection, and we'd like to confirm so the channel or not. If there's a channel, we use XT series like XTR or XTA. However, there is no channel. In this case, is the most important point is so distal end cannot be confirmed. That's why so Gaia series is a little bit difficult to use. That's why, anyways, to use XTR. And so if I will consider about that, so next step.
Okay,
right.
Scott, can I do one more thing, Roger?
course.
Because I think it's an interesting situation. Something I wrestle with all the time is coaching my partners. Do you coach your partners to go ahead and give it the old poke and hope strategy with their workhorse wires, because they'll get some of them? Or do you encourage them to say, stop and send these all to my clinic so that I can do them, because the poke and hope strategy can also result in worsening of things, especially if there's not collaterals?
Yeah, so unfortunately, as you probably know, a lot of your colleagues will do what they do, and and you don't have a lot of control over it.
That's why I called it coaching.
Yeah. An ideal world, I would encourage people to use a wire that is likely to work. And I think, your best chance is your first chance. And once you've failed with a workhorse wire, then escalating to a CTO wire makes you less likely to be successful. So in the past, I would have always started this case with an XTA. More recently, I've been starting to use the Gladius, but not the Mongo, the EX.
Interesting.
And I would vote for Gladius myself, because the issue with Mongo is it's got the weak point 5 millimeters back from the tip, and it's perfectly fine as long as you can chase it with your microcatheter and keep that weak point from buckling inside the lesion and sliding past.
Those are amazing comments. So here's what I did. So first thing, you get to the proximal cap. So here I have a Corsair Pro XS. I use my workhorse wire to get to the proximal cap with a bigger shape to get access into the circ. And that's the first comment. So I never use my CTO wires to get where I want to get to. I use a workhorse wire, I get to the proximal cap, then I switch wires. So this is extremely important. Micro channels. If you look at histopathology, we know that the average diameter of a micro channel is about 200 microns. And this is extremely important because one of my favorite wires in the world, and it's a funny thing in the cath lab now, all my colleagues are using it, it's the Fielder XTA. So I guess I have a bit more Japanese blood in me. So why do I love this wire specifically for this type of situation? Well, the first thing is it's a tapered wire. The end of the wire is 010, which if you translate into microns, it's 254. An 014 wire is about 356 microns. So already you see that by having a tapered tip, you have more chances of engaging that microchannel. And then the fact that the tapering, the way it's done, is that you have 2 centimeters where it remains 0010. And this is different from the other tapered tip wires, in which once the wire will penetrate the microchannel, because you have that 2 centimeters, it gives you a bit more support to push the wire further inside the CTO body. The 1 gram tip load also helps you do that, and that's the difference between an XTA and an XTR. The tip load of the XTA is a bit higher. And finally, two other things that make this wire perfect for this case is the fact that it's a jacketed wire with a hydrophilic coating, which means that once it engages that microchannel, you'll be able to slide inside it and advance through your CTO body. And finally, having the Act 1 technology of Asahi allows you to have perfect torque response to maneuver it. So here's 2 films showing exactly that and showing where this wire succeeded, where the workhorse wires did not. So you see my XTA engaging the microchannel and then slowly but surely advancing inside the CTO body. Now, that doesn't mean you'll end up true lumen distally, as you'll see right here. My initial trajectory actually is extra plaque. But because I have the Act 1 technology, all I did is pull it back a bit and easily access the OM1. Now, I'm not happy yet because I still have to access my mid-circ and OM2. So what did I do? I brought a Sasuke. Actually, I first changed my Fielder XTA for a workhorse wire. So I spun my Corsair Pro XS through the CTO. I removed the XTA, put my workhorse wire, and then I advanced a dual lumen Sasuke over my workhorse wire. I took the same XTA, I modified the tip just a bit. And by the way, I didn't say it in the beginning, but the initial tip I did on the XTA is a 1 millimeter bend, 30-degree angle. And with the XTA again, I went through the side port of the Sasuke and was able to access my mid-circ OM2. Once that was done, I removed the Sasuke with a trapping balloon. Then I brought back my Corsair Pro XS. I removed the XTA, and then I do this for all my CTOs. Once I'm across the CTO, I already know it's a rigid segment of the artery. So I spontaneously upsize to a supportive wire, and my go-to supportive wire is the Grand Slam wire. For many reasons. First of all, it's very safe because you only have 0.7 gram tip load, and it's an extremely supportive wire. So it's not a wire with which I wire, it's a wire that I use for support because you'll be able to deliver anything over that wire. So that's another little tip that I give you guys. So once that was done, the rest was easy. So I just did IVIS guided PCI of the circ, and I did DCB of the OM1 branch, and that was it. So thank you very much. And this is why I like the Fielder XTA for this type of lesion.
Thanks, Raja. I think there's, even though this is, these tend to be some of the most straightforward cases that we face, there's so much in this that we could unpack. One of the things, again, and we have a diverse audience. We have people who are just starting their CTO journey. We have people that are well into it. But one of the things that you did that was so nice was discover whether or not you're in the true lumen distally with your first wire by two things, injection with filling of the collaterals, and if you're not sure, then by exchanging for the workhorse wire, because the workhorse wire will not travel in that subintimal space, just as was exemplified by the first attempt.
Exactly.
So confirming you're in the true lumen, not by tip injection. Everybody get tip injection out of your head. When it comes down to XTA or Gladius, function follows form. And so the other thing that Raja has so beautifully taught you is you have to know how these things are built. If you're just picking them up because it's the next one on your list of things to try, you're never going to learn how to solve a problem that you're faced with in the middle of the case. So I thought that was really nice that you would teach everybody how these things are made. And Asahi is more than happy to come to your lab and teach you how these things are made so that you can use that information to iterate in the future.
So it's interesting, I think this whole discussion about what a microchannel is debatable. So basically, I think it's better to talk about visible channels, right?
Yeah.
So if there's a visible channel, it's not a microchannel because the microchannels are too small to be visible. And certainly, I think if there's visible channels as there were in the original one, I would start usually with an XTA. What you're really doing in this case is loose tissue tracking, right? Because we think that there's no real pathway. This is loose tissue tracking.
Yeah.
And I think it's an interesting thing. So XTA, XTR to a certain degree has traditionally been used for this, but a number of us have sort of moved a bit more to using the Gladius EX for loose tissue tracking. But again, a lot of that is about how you use the wire, and how you use the wire is not by over pushing it, not having the microcatheter too close, because obviously once you have the microcatheter very close to Gladius, it becomes a very stiff wire. Yeah. And also it depends on the bending. So if you've got a relatively straight shot, yeah, then the Gladius is a good choice. And if not, then maybe a more flexible wire is a good choice. But the big difference is that the Gladius is blunt, the XTA is not blunt. And actually, and I'm interested in your comments on this, that actually I think that sometimes the Gladius actually helps you stay in the right place by being blunt if you don't over push it. Have you got comments?
First, so Gladius is not tapered, and XT sleeve is a tapered guide wire. That is completely different. If there is a micro channel, not blunt one. So tapered one is a much better, and that is a big advantage to negotiate.
So, I mean, I think to Scott's point, you don't know if you're looking at a recanalization channel, if you're looking at a micro channel, or if you're just looking at a true functional middle of the vessel channel through the lesion. And I'm not sure. We don't have pathological specimens of these things to know what we're dealing with.
Yeah.
So just pick up a strategy. And for me, the most efficient thing, the XT wires have been relegated to certain forms of knuckling when my usual knuckle wires aren't working. And it is Gladius right out of the box or Gladius MG. They're the same wire with one minor difference.
I mean, we do have a couple of randomized studies looking at this. And there's one as recently as last year that compared Gladius versus an operator had a choice of a Fielder XTA or XTR to start with. And the primary difference between the two was not whether or not it worked or not, it was time. If you stuck with the Gladius first approach, then it cut your time in half.
May I have a comment?
No, Mauro, please sit down.
There was no tip injection.
Dr. Carlino, please.
So when we talk about microchannels, from the histological point of view, we have to remember that microchannels are represented just inside the plaque, not in the proximal cap. So first of all, I don't think that when you approach the proximal cap, it's a matter of microchannels because the proximal cap is easily crossable. Second one, microchannels are too small and too tortuous, and they are not continuous from the proximal cap to the distal cap. So in the past, I consider when I described the so-called microchannel technique, I thought that this is a good way for crossing the lesion. Then I realized that microchannel is a part of the soft part of the plaque, and that's the reason why with the HDR, we try to do all our best in order to recruitate the soft part of the plaque, included microchannel. And that's the reason why the technique worked, because basically when I inject, I deliver a viscous liquid inside the plaque, which is the contrast. Basically, I recruitate just the soft part of the plaque. And that's the reason why I suggest to use a very small amount of contrast, because it doesn't need a big amount of contrast. You have to recruitate just the soft part of the plaque, which means you must stay inside the plaque, not extra plaque. And so I think that we have to reconsider the evaluation of microchannel as a way for crossing the lesion, because it's in my opinion, is a little bit more complex.
There's one other nuance to all of this, and we've made this last 17 minutes, so congratulations.
Yes.
And that is
I knew it.
the bridging collateral. There is such a thing as a bridging collateral, and it's important to make sure you identify those and avoid those as you're crossing, because some of them can lay right on top of the vessel outside the indentation.
And to be honest, Dr. Carlino, sometimes with the HDR, people's usual comment is a case exactly like that, where if you were upfront going to go with the HDR, it would have probably worked. But again, wiring worked at the same time. So
yeah.
It works, it doesn't go extra flat.
Yeah.
You don't know the need that it goes flat.
exactly.
I consider the HDR as an upfront strategy.
Yeah.
Because you have to prepare the plaque to be crossed. And much more easier. Of course, it's not a panacea. You have to consider HDR just when you have good proximal cap. Or, anatomically speaking, and these are no more than 40% of cases, or if not, as my friend Vita learned, you have to interrogate the plaque in order to find it. Then you can consider deep HDR.
Okay, we better get rolling. Next up, good friend and colleague Jarrod Frizzell from the Christ Hospital in Cincinnati is going to teach us all how to get better, in reference to my earlier comments about people being on various parts of their journey. I look forward to your advice on how to help them get better.
All right. Well, I would say good luck. So my name is Jarrod. Let's talk about this, disclosures. So what does it mean to get better? What does this mean to you? Is it about your success rate, your complication rate? Everybody wants high success, low complications. We're talking about procedural efficiency, being able to do things faster. Maybe that helps the flow in the lab. Maybe that helps you get home to your family. Financial viability program. Do you want to be the person that does no angiographic turndowns, to be able to do everything? What does it mean for you to get better? And it can be really tough for you to focus on that and figure it out. It takes a lot of introspection. And frankly, most of us aren't really great about introspection. Conferences like this are a great learning experience, but it can be overwhelming. When I counted out of curiosity over this 2-day conference, there's 112 faculty, and there's actually very little talk about techniques. And so you really have to, it's on you to figure out what you need to do. And even if you go out to a course, they have various focus depending on who's sponsoring it, depending on who's hosting it and all that. So what I'm going to do is I'm going to talk a little bit about how I've improved, and I'm going to show you my own data for that. Folks that know me know that I very assiduously track all my data, and that's part of what I'm going to talk about in this discussion. What I'm not going to do is compare myself to anybody else other than myself. Just kind of my personality, I never really wanted to be top of the class or anything like that. My motivation was always intrinsic to that. What I want you to do is think about how you can challenge yourself and take or leave any of this as it applies to you. And one of the most important things that I'm going to hit again and again is it's really important to find your people. You can't get better alone. You are going to need help, and you can help others in turn. And so how to get better, there's 3 easy steps. 1, collect your own data. The other one's actively review your own cases. And I'm talking about reviewing your successes. Most of us spend a lot of time perseverating over our failures. But if you're even halfway good, most of your cases will be successes. And there's always room for improvement. I did a great Stingray case earlier this week. It took me about 35 minutes from lidocaine to close, and there's already ways that I could have saved 3 minutes off of that. I mean, there's ways you could do it with every single case. And again, find your community. And this is real talk, person to person. This isn't social media, okay? This is sharing cases, being open, being vulnerable for that. One of the downsides of social media is that people tend to post show-offy cases. And I'm just gonna say this flat out, is that if you only post your wins, you're a loser. Don't do that. The other thing is that PCI is not a pill. One of the big things about PCI, as we know, is that technique matters. How you do it matters. And that's actually one difference between PCI and surgery in general, is that the surgical approach, it tends to be more of the patient factors that give all of the risk. But for PCI, it tends to be more of the operator that gives the risk or not, and how they do it. And use literature, quote literature, understand that as your starting point. But if you're doing any sort of appreciable volume, you owe it to yourself and you owe it to the patients to be honest with them as far as what you're able to do. There's a big difference between somebody who does a bunch of CTOs and say it has a tamponade rate of less than 1 out of 200 and somebody else that quotes a risk of catastrophic events of 2 to 5%. It's huge. And there's opportunities for improvement in both of those. The other reason to collect your own data is to look for patterns. I'm very consistent in the way that I take notes about my case and stuff. It makes it really easy for me to go back and look. I'll show you some examples of that. It also promotes consistency in how you approach things. And if you don't own your own data, somebody else will. So whether that's your hospital, whether that's your partners, I mean, the common impression from a lot of people is like, oh, your CTOs are super high risk and you only get like half of them anyway. And you can show them like, no, actually, this is what I actually have. The common impression of how learning curves go is sort of like this, right? Is we start off and we kind of suck and we know it and it gets beat into us. And eventually there's a steep learning curve during training and we go up and up and up. And then by the time you're ready to graduate fellowship, you're already, king of the pile, right? You're taking pity on these poor like first year fellows that don't know their own way around and stuff like that. And you think you've mastered it until you get out and practice, right? And then you have a whole new learning curve. Oh my gosh, I can't look behind me and like ask what size stent to put in or how to interpret this IVUS. It's all on me now. And then eventually you reach what's called in the literature a plateau of mastery. But I would argue that it's really the plateau of complacency. As people tend to get stuck in their ways and they figure out where their natural point is and they just kind of settle there. Whereas where I think it ought to be is as you start, you need to start pushing yourself. And this is where it can be really, really hard to do, is to push yourself and not have anybody else behind you doing it. And whenever you push yourself to try something new, you're going to get a little bit better at it, but then you're going to fail at it as you try something new. And then you're going to push yourself even harder. And then this is where it helps to have your community behind you so that it's not just you alone. And then over time, you just should keep going up. And then at some point, this will fall off, and that's where you should, you may think about stepping back, which is a whole different topic. So how to get better, this is essentially the foundation of it. So just do the cases, do the active review. and then find your community to bounce things off of each other. I have about 10 to 15 people that I communicate with on a daily or every other day basis. And if you broaden it out to like with the people I talk to within a couple of weeks span, there's about 25 people, and we're always throwing cases to each other. And that's how I've really, really pushed myself to get better. And real improvement has to have other people. Don't be a silo. If there's one thing that I want you to take away from this entire talk is that you are not alone. Every single person in this room is on their trajectory to get better. And we're all here to help each other out. It's not about me versus you, it's about me and you. Improvement, again, incremental and active process. You don't get good just for doing cases. We all know somebody that's done the same thing for 30 years and they're just as good or as bad as they were 30 years ago. Track yourself by owning your data, figuring out what you want to do versus what you need to do. Again, think critically about your cases and find your community. And if you know somebody that's better than you, ask them for help. Take your ego out of it. And it doesn't matter if they're 5 miles away or 500 miles away or 5,000 miles away. We're all in this together. So what I did, and what I implore you to do, is think really critically about what your weak points are, okay? You want to be strong. You don't want to have any chinks in your armor. When do you feel stressed during a case? When are you uncertain? Those are some good places to start. So these are a few of my examples. I don't have time to go through all of them. And I actually, after looking at the program, decided to change this at the last minute. So what I'm going to start with then is my Stingray journey, because this was my weakest link for the longest time. So in 2022, I did 185 CTOs and only 2 Stingrays. That's embarrassing, flat out, okay? I'm sorry. Like, this is something that I could always make up a reason not to do it, right? I'm really good at retro. You know, it's hard to get the Stingray catheter down there. It's very finicky, like, it's not a good landing zone, or I can just start out if I need to. And so I was like, okay, well, this is my weakest link. I'm just going to face it head on, and this is what I'm going to do. So I did purposeful practice. This is what I'm going to do, and made that an explicit goal of mine. I talked about the Stingray and the whole process in the submental space with others a lot on how to do this, because I knew people that were better than me at this, and I asked them for tips. What am I doing? I completely changed my approach. My choice of anaerobic microcatheter, when I started, I was a turnpike spiral kind of person, and then I went to a Corsair Pro XS, and I realized I was having struggle because I wasn't making an appropriate channel to go down there. That was one of the factors, and so I changed to a Corsair Pro as my default. I stopped thinking about, oh yeah, this will be a good Stingray, and instead, I just threw it down there. Because what if I fail? Doesn't matter, right? If I get it, great. If I don't, then I've already done the vessel prep and I can move on to the next strategy. I also got a lot more aggressive about my proximal vessel prep, about using balloons earlier in the case, shoving a guide extension all the way down. I'll show you a little bit about the Mongo twist. This is something, I'll be honest, I haven't heard anybody talk about before. And another key to unlocking this was a Seldinger approach for me, is doing a through and through and then catching it on the way back. I also completely rethought my entire understanding of the subintimal space. And this is an entirely different topic that fortunately I was asked to write about, and so with some help from Jesse and Taishi. I won't do it all here, but it was really important to me unlocking this. This is what I mean by the Mongo twist. So the thing about the Gladius MG, Aaron already mentioned how it has that hinge point. And what I learned was that the way that the Mongo laid out predicted how the Stingray was going to lay out. And I can manipulate this. I don't spend time hunting for the views. I make the view come to me. So as you can see, it comes out. You can see the clear J of that hook. And then I pushed forward and I twisted it so that now it's flat. And then this is how the Stingray laid out, just like that. And then bam, you're in. This is a Seldinger. So I know we're looking at all these sternal wires. I also do cases that aren't post-cabbage. So that's clearly going through the vessel. You don't even have to see like the angiogram to know that. And as I go through and through, and then I flip it over, and then I'm probing on the way back. And then eventually it just goes in. So hook it forward, flip it over, and then probe on the way back. And then you're in. And so as I started doing it, I was doing cases that I was like, okay, there's no way I'm going to get this with a Stingray, right? This is like right out of bifurcation. But so what? So what if I don't get it? Then I have other options. I can flip to retrograde. I can do slash. I can do all this other stuff. And I started pushing myself. And so this is what my data looked like. over the past few years is, again, those were those 2 Stingray cases. So then it was at the end of 2023 when I decided to really push myself. And yeah, my success rate went down because I just started throwing it down there. But I will tell you, one other thing that I learned from this is that every time I pulled a Stingray, the case ended up being a success. Because I either got it with a Stingray, I got it retrograde if I didn't do it, or I ended up having a pretty good star result because I'd done all the prep going in. And you can see, I didn't realize this until I was looking at it, is that this actually matches that little ideal, getting better, getting worse, getting better again, and ending at a higher point. And so far this year, I mean, I've only done a little over 40 cases, but I'm doing even better. One of the things that I realized in doing this is that the difference between being an okay CTO operator and being a good CTO operator is being able to go retrograde. But the difference between good and great is what you can do antegrade. One of my annoyances at conferences and stuff like that is whenever people's like, oh yeah, I would just go retrograde for this. Well, like 20% of the time you can't get retrograde. So what are you gonna do? I mean, I've gotten 2 out of the 3 of the past osteo RCAs antegrade by just throwing a wire down there and seeing where it goes and doing that. And my entire strategy then has shifted. And so you can see these are my proportion of cases. And as I've gotten better antegrade, I've actually done retrograde a little bit less. So now maybe I need to work on that seesaw and get there. But taking it one step at a time, paying attention, and being conscious of it. So I'm going to, in the interest of time, I'm just going to skip to the end, and we can go back and talk about any of these. And obviously, just email me, and I will give you this entire presentation. I don't care, and I will talk to you at length about whatever you want to talk about. You don't get better just by doing more cases. You don't get better by yourself. It's an active process. It doesn't just naturally happen or fall from the heavens. And be honest with yourself, and get help. Real peer review, coaching. And one last thing I'm going to share. And so this is something that I got permission to share from patient's family, and pushing myself to get better. I did something last year that was, I won't go into details about the case, but it was really neat. It had never been done before. I did a lot of work, background work into it, worked in a cadaver lab, and it worked out really well. And the patient's daughter sent me this text yesterday. And it says, I've been way too emotional the past couple of days thinking about it. I worry that it may not have reflected how deeply grateful we are. I just need you to know that you gave me more time with my dad. You gave us memories we wouldn't have had. I'll never stop thinking about that. And I will always be thankful for that. It's incredibly crazy that he could not get out of a recliner for months prior to the procedure you did. But now he's out there hiking at Hocking Hills, celebrating his 70th birthday, crawling around the floor with his grandson, doing handyman work around the farm. You made that happen. Thank you. You made a huge difference. Thank you. And that's why we get better. That's why we do this, okay? So I'll end a couple minutes early. Thanks. I know when I get rolling, it's kind of like drinking from a fire hose, but there's just a lot to it.
No, thanks, Jarrod. That was a fantastic presentation, and it always resonates with me when you tell us to compare ourselves to ourselves, not yesterday, not other people today. And it just is based upon what you all know as people who understand medical literature. It is a completely invalid experiment to compare yourself to somebody else. By the time you're 5 years old, the differences between your parents and your siblings and the interactions and the things that have gone on in your life are already uncontrollable. And there's just no way to do that. And we can't randomize a case. We can't take a case and have somebody do it and then have somebody else do it and see whether or not it's better or worse or the same. So great advice in everything you do in life, especially in this field.
So I would just add that I would feel like for me personally, 2 of the most important inflection points in my career is number 1, deciding that I want to be Bill Lombardi when I grow up. And number 2, deciding that I sure as hell did not want to be Bill Lombardi when I grow up.
All right, is Bill here to defend himself?
Yeah, but the biggest one was finding that community, and I did that through Bill.
Got a question from the audience.
Yeah, Jarrod, that was a great talk. Could you share a little bit about, you say you track all your data.
Yeah.
Just a little bit about the practicalities of it, how you track it, what exact metrics you are.
Yeah, so I'm happy to share my template with anybody that wants to. And so I have a big Excel spreadsheet, and on there are, let's see, I'm trying to think of like how the columns go from left to right because it's quite a bit. But it has, age, vessel, whether or not they're post-cabbage. I have an auto calculation of JCTO score. I have the successful approach that was used. I have my access to it. I keep track of were there any complications whatsoever. or even kind of maybes, because I'm doing this for myself. So, we know that, self-reported is different than like core lab. So I'm not trying to prove myself to anybody. So anything whatsoever, like, sometimes I'll like maybe a perf whisper, I don't know, weird contrast. And then mace is a column. I have, trying to think of left to right. I have my fluoro time, gray, contrast, sedation time, room in time, room out time, procedure start time, which is lidocaine stick, procedure end time, which is when it's documented as procedure end, which is like closure, because one of my other things is efficiency. And then I have a notes section, and then I have multi-vessel. And then in my notes section, I'm very consistent about what I put in for like different things or whatever. And I have off to the side a bunch of formula that I use to grab data from that, including some of that free text stuff. So it's easy for me to say, like, this is how much Stingray I got, this is how much whatever. It's a lot, I know, but that's what it is. And one of the key things
All right,
is,
if you didn't take good notes on that, text him. He'll give you the.
yeah. I mean, I'll just share it with you. Yeah.
I might just make a couple of comments. I mean, I really enjoyed your talk, and it sort of gels with the way I think about things. So if I reflect on my career, that, probably the most important thing has been mentors. Tushikani was a great mentor of mine. Bill, Simon and Colm, great friends and mentors, and doing cases with them or having them come to my lab and doing cases has been a huge part of my learning. The second thing is that I think, that continuous learning thing is really important. And I learned this from Bill. He sort of set himself a couple of goals every year of things he wanted to learn or get good at, and I started doing that. So like last year, I was like, well, I've got to learn CTCA because this is the future. If we're going to be doing complex angioplasty, you can't have a radiologist reporting this. We actually have to own the imaging and understand the imaging. So I went away and did a CTCA course and started to try and build competency in that. The year before it was 3D wiring. Really tried to learn these sort of skills. So I think, thinking about, some target and setting that target for the year is a really good way of progressing your career as you go on.
So I want to ask Raja, as one of the younger members of the panel, fewer gray hairs, that's what I assume, you're younger. Finding mentors, there's lots of us out there willing to do it, but finding mentors can be a challenge because there's people mentoring who may not have the best ideas. How do you use discernment to figure out where you can go for reliable information, and can you help the audience?
I mean, this is a very on-point question. I mean, as a lot of you may know, I lost my own mentor, right, Dimitri, that we lost last year. So it's still very painful. But luckily for me, and and the other thing is we're going to celebrate 10 years of the creation of this whole CTO chip fellowship stuff. It's unbelievable how fast it passed, this project that you guys led about training very junior people to do very complex stuff right out of training. And thankfully for us, these first few guinea pigs, we ended up pretty okay. But having mentors and being surrounded by people who are going to have your back in your successes and your failures is extremely important. And what I felt, and what other of Dimitri's former fellows felt, is that we were spontaneously supported by the rest of the community. I looked to Aaron, I looked to Scott, I spoke with Bill last year, and it's like a big family. And in your own institutions as well, even your older mentors, older colleagues that don't do CTO PCI, they still have like 30 years, 20 years down the belt, and they still can help you for the emotional stuff, the psychological stuff. Because you don't need only support for the technical stuff, you need support for all the other stuff that happens in our lives. So I'm thankful to have been adopted by the rest of the older generation.
I want to just take one more minute and give Jarrod a chance to introduce the people you have here, because I know you said you collect your own data, but you still have a massive amount of support from some folks in the audience. So you want to introduce people real quick and tell them what they do for you, so that people can have an idea of the resources they need to fight for if they want to build a program like yours?
Absolutely. Because you're not in this alone, and it's not just our colleagues like across the country, across the world. I couldn't do this without the people in the lab. So just calling them up like in order that they're down there Rachel, cath lab nurse. She's the one that's about to turn really red just because I'm pointing her out. But yeah, I mean, I'll be honest. If you're talking about moving with, two sets of hands acting as one, it's she and I at the table together. Next to her is Evan Luce. He's one of our more senior members of the cath lab. We won't say how senior, but Evan's been doing this since, the Grunzig days, basically. And he's a tremendous resource in the lab for helping with all sorts of practical and technical stuff. And then skipping a couple over, Shelly, I want you to actually stand up. So Shelly Bruns is my CTO coordinator. I could not have anything that I do at Christ Hospital without, stay standing for a second, because I'm really gonna embarrass you. I could not do anything at the Christ Hospital without her. And she actually took it on herself to found this national CTO consortium for the coordinators that Asahi sponsors. There is a webinar that's now on YouTube that anybody can look at, but if you want to know how to get started, how to get a program started and continue that, Shelly is the person to do that. She handles everything. So it's absolutely wonderful. And I could not do that without any of them. Thanks.
To add on to the mentor part, we have Elaine here and Kara from Dr. Grantham. So we also need that mentoring support. We learn from each other, just like you guys do for community. So if you have a coordinator or you're starting a program, please get them on board because we love it. The more the merrier, and the more we learn, the better we can run programs. So please reach out to us, just like Dr. Frizzell said, we are available.
Okay, I'd like to introduce our last speaker, Maoto Habara, who's from Toihashi Heart Center, the home of CTO PCI. And he's going to be talking to us about the strategic use of ADR and CTO PCI to improve procedural outcomes.
Thank you so much. My name is Maoto Habara from Toihashi Heart Center in Japan. That is a very rural area in Japan. At first, my topic is a very technical issue. And the overseas physicians are perspective Japanese CTO PCI. From positive thing is also, I think it's very dedicated and precise wire control handling. And IVAS is used as a strategic navigate tool. However, on the other hand, I think I hear very often that the procedure can be time-consuming and strong commitment too much to the lumen crossing and avoid knuckle wiring or ADR. And a highly specialized approach that is not easily reproducible. However, so recently that is a little bit changed. That's why I will talk about that. So that is a 3D wiring and the penetration plane method. That is very confusing, I think so, I know. That is, however, we really emphasize precise control and integrated approach. I will show one case. This is a circumflex CTO. As usual, we calculate the perpendicular projection, which is orthogonal view of the sort of to the digital target. And this is a software, SFLAX-Edu, developed by Asahi Intech. According to this software, we can calculate the perpendicular view for the digital target end. That's why before the procedure, we can calculate that. So this CTO is the area coder and the area coder. That is the best view. And so this is the two view for the circumflex distal end. The guide wire is very close to the distal end. However, this area view is a guide wire looks good. However, LVL view, guide wire tip is the opposite side. That's why, I will skip about the detail of the 3D wiring. Anyway, I will rotate counterclockwise and push advanced. And then finally close it to the distal to lumen. This is our strategy for the 3D wiring or integrated wiring. Of course, we continue about uphold this style. However, we have to improve about the knuckle wiring or ADR. I will show one case. This is a LED CTO, very calcified and a relatively long one. And there's a not so good collateral from the retrograde. And the CTO just started around the diagonal branch. And I started retrograde, but there's only one retrograde that is very close to the distal end. And I negotiated double lumen catheter. That's okay. However, retrograde wire cannot up to the retrograde. That's why. So give up for the retrograde wiring, and I started to retrograde. And of course, now this is a very stiff wire. It's a little bit risky to go outside of the vessel. That's why. So I use the Gradius MG Mongo for the knuckle wiring, and that is go to the diagonal branch, and so I dilated diagonal branch, and so after that I negotiated the Gradius MG to LED. Like that. So that so I mentioned that Japanese operator recently used a knuckle wiring with Mongo. And unfortunately, that is dilated LED, and I checked the IVAS. Unfortunately, the guide wire is a subintimal space. That's why so I negotiated retrogradely, and that succeeded this case. That's right. So using a knuckle wiring is increasing about the frequency. And so let's talk about the ADR. And the ADR practice in Japan has evolved in a distinctive manner with the Confidenza Chip Pro. This is a new guide wire. This is the same as the Conquest Pro 12, but also chip is like a Gaia. That is a sharpened chip. That's why it's so very stiff, and penetration force is much better. And the anterior IVAS, that is Thermo IVAS, Japanese company's one. Tip to the imaging core is only 8 millimeter. That's why it's so good for the IVAS guided wiring. And Stingray ADR, of course I know, that is a very good strategy. However, that is by the angiography. And chip detection ADR, that is IVAS guided ADR puncture. I will show some case. So when I go to the anti-grade wiring, the guide wire go to the subintimal space. At that time, I negotiated the second guide wire. And the first guide wire is IVAS. And the second guide wire is a microcatheter, and that's a confident. And from the IVAS guiding, puncture from the subintimal space to true lumen. You can see the true lumen at 6 o'clock. And the IVAS is located on the subintimal space. That's why puncture from to the subintimal space to the true lumen. And so during the procedure, I asked each second operator to navigate the IVAS like that one. From distal to proximal, proximal to distal, like this one. Beyond the second guide wire tip, like that. That is angiography. Back, forward, back, forward, back, forward. And so I will show the IVAS. That's corresponding IVAS image. That's forward, back, forward, back, forward. You can see the second guide wire. Second guide wire is coming appears and disappear. Appears, disappear. Disappear means so that is the tip of the guide wire. I will show the still image. This one. IVAS is from the proximal to the distal. Proximal to distal beyond the second guide wire chip. And the green arrow is the first guide wire that is located in the IVAS catheter. And the second guide wire is 9 o'clock and 8 o'clock. And 8 o'clock and 6 o'clock. This is the second guide wire. That's right. So you can see the second guide wire, 9, 8, 8, 6 disappear. That means tip of the second guide wire is here. And I will show the more image. This is the second guide wire, the white one. So that so guide wire is tip is 6 o'clock. That's why the image of the second wire is like that. So we have to rotate clockwise a little bit and puncture. This is our style of the ADR. This is a puncture moment. The guide wire tip is like that. What? 7 o'clock? Not yet. Not yet. I advanced much strongly. Punctured now. You can see the guide wire enter to the true lumen. So now I will show again. The guide wire IVAS is located in the subintimal space, and that is the second guide wire. I navigated to the clockwise, and so that is towards to 8 o'clock, and then I punctured and go into the subintimal space to the true lumen. This is a chip detection ADR. And so this is an algorithm. In Japanese, physicians like to use such kind of the algorithm, anti-grade wire escalation. And if that was failed, we previously switched to the parallel wire technique or retrograde approach. And if failed. Last resort, I was guided, but also I would like to penetrate to the intra-plug tracking. That was the previous our style. However, recently, the SWOT algorithm was a little bit changed. When I negotiate the guide wire to the distal, if that was failed, we consider parallel wire technique or retrograde or I was guided ADR. That's why the prioritize of the ADR is much higher as compared to previously. And so finally, I illustrated the typical case of the ADR. That is the circumflex CTO. First, I negotiated guide wire to the distal end. However, that angle is so acute. That's why anti-grade wire was so difficult to negotiate. And you can see some collateral from the right RGA, but so that is very close to the distal end. And I negotiated this retrograde. However, puncture was a little bit difficult because there is a not so big margin from the retrograde, and then the retrograde wire was prolapsed to the circumflex. That's why I failed. And I tried to use a kissing wire. However, kissing wire was also failed. I decided to perform a chip detection ADR. This is a guide wire and the IVAS. You can see IVAS is completely subintimal space, and the true lumen is over there. Okay, and so we are looking for the best position of the ADR. This is a true lumen, and around there, that is also a good point to puncture from the subintimal space to true lumen. The image is like that. This is a true lumen. IVAS is a subintimal space. That's why I try to negotiate second guide wire from this direction. And this is the corresponding IVAS image of the puncture, like that. And this is the IVAS image. IVAS guide wire was advanced from subintimal space to the true lumen, like that. That is also recently widespread in Japan, the chip detection ADR. This is the final angiography. And this is summary. In Japan, we have traditionally take pride in meticulous anti-grade wiring. However, with increasing emphasis on time efficiency and procedural simplification and safety technique, such as knuckle wiring, and now being used more frequently. And furthermore, with the widespread of adoption with chip detection ADR has become broadly accepted. And in conclusion, even within Japan, CTO PCI strategy have become more diverse, and the role of ADR varies among operators. For me, however, ADR clearly contribute to improve procedure success rate as a last resort option. Thank you for your attention.
Thank you, Maoto, and that was very nicely within the spirit of the title of the meeting, which is coming together and learning from each other. Your demonstration of tip detection ADR fascinates me so much. I can't wait to have access to the technology that we can't get in the US yet. But the thing that impressed me most was your 3D reconstruction. And I'm just wondering if you're working with Terumo to get machine learning and make those images overlaid on top of that IVAS image to help those of us with 3D reconstruction challenged brains make that happen in real time.
Yeah. I think so. That is one issue for the confusing of the IVAS guiding. Previously, Japanese operators say that wire is here and the IVAS is here. That's why that corresponding to the angio image, and the angio image is 5 o'clock, something, blah, blah, blah. That is very confusing, I know. However, this system is more simplified, because we can see IVAS image and the true lumen and the wide wire is here, and just rotate, and so second operator just only move and confirm which direction of the tip And so we can confirm that chip detection is correct. That is a puncture. Of course, so that isn't. This is a very. I skip the detail of the procedure time. Of course, sometimes it's very difficult. That is depend on the calcium or the vessel bending or something. But as previous IVAS image, to compare a previous IVAS guided wiring, that is much simpler and also much easy, I think.
So Maoto, obviously we don't have NTL and we don't have Conquest Pro ST. I've done some cases, not many, I'd say 3.
Yes, that is a.
And could you maybe comment on how we can, what equipment we can use outside Japan to explore this technique?
Yeah, thank you so much. That is a big important point. The big limitation is this technique is dependent on the thermal IVAS and the confidence ST. However, recently I have some experience to perform such kind of the technique in the foreign countries. In those situations, I use Boston IVAS. Volcano is also a little bit too much bulky. That's why. So I use Boston IVAS, and tip is a tip to the imaging core is a 20 millimeter. That's why. So I sometimes cut of the tip, and and sometimes the pushability is not so good. That's why. So before advanced Boston IVAS, I dilated 1.5 balloon and the entry of the CTO and the subintimal space, and I advanced the Boston IVAS.
And do you have a comment? The last case I did with a 40 megahertz catheter.
Yeah.
And it was actually easier to see the tip.
Yes.
With the 40 megahertz catheter
Yes.
compared to the 60 megahertz catheter.
60 mega is much better. Yeah, that's why. So New Zealand and Australia, I think that's so 60 megahertz. China one, IVAS machine are there. I think. Yeah, that one. Yeah, that I have some experience to use that one. That is much better compared to the Boston IVAS.
And just, practically, if you don't have Conquest Pro ST, do you just use Conquest Pro? Or I know you probably always have ST in your bag.
yeah, I know that.
I think I've stolen a few out of your bag.
I saw that. So the lot ablation and so to make the chip more shape, but that's why I have no experience that. I use so Confidence Pro 12. Yeah, but also of course, so the success rate is much relatively low because also the equipment is much important.
Yeah, I find like when I've tried this a lot and I just can't get this to work, and I wonder how much it is the ST, because it seems like in the images you showed of IVAS, you're punching back in relatively disease-free segments, and a Pro 12 or an Astat or something like that just kind of slides across. It's not catching on anything to dig in. It seems like the ST seems to be, key to this.
Yeah, that's right. So chip shape is much important to puncture. Yeah, that sometimes that slip.
That was the whole point of the little barb on the Stingray wire. So that's been a recognized challenge of the procedure for a long time. So maybe a Stingray wire would be helpful at catching it and punching.
Yeah, that's right.
I mean, if only we knew anybody that could help get the ST outside.
As initially, Stingray, Confidence Pro ST was developed as a Stingray wire by Dr. Tsuchikane. That's right. So that is a big advantage because with the stick.
So I'm just going to do a little plug here. So one of my colleagues, Eugene Wu from the AP CTO Club, has done a lot of work on 3D wiring, and most of us who've watched Okamura's presentations end up confused and with a headache. I think that would be most people. But Eugene's done a great job of trying to simplify 3D wiring
I agree
with adapt wiring and solution wiring. So if you want to learn more about that, he has a YouTube channel. Look up CTO Demon, and you'll find out all you want to know about 3D wiring.
Man, hopefully he's okay after the Demon Hunters.
Yeah.
All right, that's a wrap. Thank you all for your attendance. Any other questions, comments? Panel will be available. You can come up and talk to us or meet us later at the meeting. Thanks for your attendance.